most of the higher countries in the world. So only 3 papers, including 2 case reports, are published about the transjugular insertion of a biliary stent. Actually, this session is an embolization session, but I want to, it's an honor to introduce the biliary stenting through the heparin vein. So I'm doing work from Asan Medical Center, Seoul, Korea. So let me show you one case. This patient, you can see the massive ascites, and this patient also suffered from the jaundice and cholangitis. So it is this patient need immediate biliary drainage, but this patient also have coagulopathy. So the percutaneous intervention is very, very difficult or even impossible. So we can consider the endoscopic approach in this patient, but this patient has occluding the duodenal stent. So the endoscopic approach is also impossible in this patient. So how we can do the biliary drainage? So we can do the transjugular approach in this patient through the heparin vein, and you can puncture not portal vein, violence, using the porapitometer. And this is procedure is similar with TIPS procedure. So now I'm introducing the indications for TIPS procedure. So in this patient, we decide to perform a transjugular biliary intervention. So after negotiate the right heparin vein through the knife incisions, and then we puncture the dilated common hepatic duct like this. And then we obtain the cholangiography using the 5-inch catheter, and you can see complete obstruction of the distal common bile duct. So we decide to perform a permanent metallic stenting in this patient. And this patient also had duodenal stent. So when we put the biliary stent within the duodenal stent, the biliary stent would be obstructed immediately due to the extension compression by the duodenal stent. So in this case, biliary stent should be placed, tip of biliary stent should be placed beyond the distal part of the duodenal stent. So in this case, we used a very, very long biliary stent like this, and completion cholangiography showed good biliary stent flow. So we successfully removed the 5-inch catheter and the 9-inch catheter without any embolization procedure of the puncture tract. So this is not an embolization procedure. So as I mentioned, the inpatient with the duodenal stent, the biliary stent, tip of biliary stent should be placed beyond distal part of the duodenal stent, and we already published about this article. So we developed a low biliary stent like this. This is not available in the world, but in some countries you can use this kind of stent. This is the EPTFE covered biliary stent. We especially use in patients with combined duodenal and biliary obstruction. Let me show some important technique for the transjugular insertion of biliary stent. This is the first case report published in 1991. At that time, the authors also performed the transjugular biliary stenting. So it was very safe and effective method, but they reported only one case. This patient had malignant duodenal biliary obstruction, and this patient also had massive ascites and biliary obstruction and multiple interhepatic metastasis. And the serum bilirubin level was more than 20 milligram per deciliter, and the CRP level was higher. So this patient needed immediate biliary drainage, but percutaneous procedure is very difficult and or even impossible. Also, the endoscopy which is possible in this patient. So we decided to perform transtubular biliary stenting. So, however, as I mentioned earlier, when patient have duodenal biliary obstruction, the duodenal stenting is should be firstly performed, and then subsequent biliary stenting should be performed to maintain patency of the duodenal stent and the biliary stent. So in this patient, we initially performed duodenal stent using the copper stent, and then on the coronary CT scan, you can see the right hepatic vein and the right posterior coronary vein is very close. So it is relatively simple and safe and easy to puncture right dilated right posterior bile duct from the right hepatic vein. So we successfully punctured just one time attempt, and you can see the very short track between the right hepatic vein and the right posterior hepatic duct. And mostly the track embolization is not necessary because the laminar flow of the hepatic vein cannot influence the interhepatic bleeding, interhepatic bile duct bleeding. So you don't worry about track embolization after successful transtubular biliary intervention. So we successfully performed the subsequent biliary stenting after duodenal stenting like this. And after completion of cholangiography, I usually aspirate the interhepatic bile juice through the 5-French or 9-French sheath, and then just remove the catheter and the shoes. So one follow-up CT shows this patient was allowed for the total diet, and the serum bilirubin level was significantly decreased 1 week after TIPS procedures. And also you can see the patent both duodenal and biliary stent. And the serum bilirubin level and ALT level was normalized during the follow-up period. Can I play the video? Can you play the video, please? So let me show you the case. This is an pain. This patient also had a similar situations. So I punctured bile duct. So at the time, the posterior bile duct branch was punctured, so I depunctured the main right posterior right hepatic duct like this, and I confirm interhepatic bile duct dilatation, and then I negotiated the guide in catheter and obtained cholangiography and the duodenography. And you can see the biliary distal septic obstruction. Also, you can see the duodenal stricture or obstruction. So I decided to perform the long biliary stenting. At the time, prior to biliary stenting, we performed the dilatation, and we initially put the bare metal stent to treat the study. I successfully deployed the bare metal stent, the CBD. Cholangiography after bare metal stent shows poor stent function with the distal CBD, and also you can see the duodenal stricture. So I decided to perform additional long biliary covered stenting like this. The usual length of this stent is 23 centimeters. After stenting, I aspirate the interhepatic bile juice through the 9-French sheath, and I just remove the sheath. This is a second case report from China. the transtubular stenting was technically successful in 83% or 0.3%, and no procedure-related complications. Standard patency after stenting was 100%, and median patient survival time was 4.5 months. We performed a prospective study for the transtubularization million stent in 12 consecutive patients. Transtubular stenting was technically successful in 92%, and we experienced two minor self-limiting hemophilia. This patient did not require any transfusion or embolization technique after biliary stenting, and successful internal duration was achieved in 73%, and median patient survival was very poor, only 19 days, because of the very advanced stage of the disease and underlying conditions. So the transtubularization of biliary stenting can be an alternative way for the internal biliary drainage. And the TIPS procedure is technically feasible, safe, and effective, especially in patients with massive ascites with or without combined coagulopathy or internal body metastasis. Thank you very much for your attention.